Sauer. I'm the CEO of the Washington State Hospital Association, and we're really glad you joined us again this week for our media briefing. We've got some great guests with us today. We're both from Eastern and Western Washington, and we're excited to have them. So we have Dr. Andrea Carter, who's the Chief Medical Officer at Samaritan, which is in Moses Lake, and they have been doing some mass vaccination clinics in Grant County. Really exciting work over there to get a big group of folks vaccinated, especially in this time when we're really wanting to gear up vaccinations for folks in the agricultural industry, and a lot of food processing that happens over there. So we're really thrilled about that. Teresa Atkinson is here as well. She's the administrator of Grant County Public Health. And so she'll be joining to talk with Dr. Carter about their work together, a real model of how public health and hospitals can work together to quickly vaccinate a wide swath of folks who are especially high need. So really appreciate you being here as well, Teresa. We're also glad to have Dr. Amy Markovic, I got something in my throat, she is the CMO from Overlake. And I'm sorry, she's the internal medicine doctor from Overlake. I apologize, Dr. Markovic. And she's been, so as you know, Overlake, you may not know this actually, Overlake in Bellevue was one of the first hospitals hit with COVID patients that came out of a life care nursing home. And so you all have been caring for Overlake for COVID patients almost longer than anyone. And I know you've seen really tremendous shifts in how folks are cared for. And so I think that will be really interesting for people to hear. I'll start with a few opening comments. I just want to make sure that folks noticed, I think we mentioned this last week, the governor has announced that today, the whole state moves to phase 3. One of the metrics for moving to phase 3 is that ICUs statewide can't be above 90% occupancy. This is a very unusual metric. We're the only ones in the country we know who have this. Everybody has an ICU metric, an ICU occupancy metric, but they are usually county-based or at most like a region-based, 2 or 3 counties together. We don't know of any other state that has a statewide metric. The governor's office put this in place. In response, they said, to the hospital's cooperation in caring for patients, making sure that patients could move, staff, supplies, medications, ventilators, PPE, and they have seen a level of, they've said to us, they've seen a level of cooperation among the hospitals here that the governor's peers around the country hasn't seen either. So it's actually a huge gift to the state and its reopening, because the chance that every hospital, that all the ICUs in the state will get to 90% occupancy is very low. You think about just the capacity is waxed and waned across the counties. And so it really does, it's a key piece of allowing the state to move forward. So I want to really express our gratitude to the hospital leaders who came to the table, worked out a written agreement very early in the transferring of patients, and made an agreement that no hospital would ever reach crisis standards on its own. It would have to be either a full region, like all of Eastern Washington or all of Western Washington, or probably even just the whole state would have to reach crisis standards. So that's a really big deal. And phase 3 is a big deal. It's one that we are glad the state is moving forward on. Also have some nervousness about it. Hope that people will really continue to wear their masks and social distance. Dr. Carter and Teresa, I'd love for you to talk about this. I spent time this weekend in Eastern Washington, actually in Grant County, and there were quite a few people unmasked inside places. And so that was concerning, more than I see in Western Washington. So I think really continue to call on our communities to wear their masks, social distance, do all the things that protect you from COVID. Those are the same things that will protect you from the variant. So that's critical for us to stay in phase 3 and to have the possibility of moving into a further phase. I don't think that our state will be able to move forward if we don't take those protective measures. And then we'll have always a chance to talk about vaccination in this group. And I think I'll actually probably leave that to Dr. Carter and Teresa, because you all have been much more on the ground, but we're excited about vaccinations moving forward. We're excited the governor has accelerated the phases. We're excited about the May 1st. Everybody can get a shot announcement. I think what we have seen from other states is that the simpler the phases are and the faster they're moving, the more people you can get vaccinated the most efficiently. So those were all very welcome announcements. All right, why don't we start with Dr. Carter and Teresa. Tell us your experience in running these mass vaccination clinics, and how are you reaching folks who may be hard to reach?
Sure, Teresa, I will start and then you can jump in. So I'm Andrea Carter. I'm Chief Medical Officer here at Samaritan Healthcare in Moses Lake. And I will just start out with when the vaccines first came out, we were one of the lucky ones that had a very low temperature freezer. So we were able to get the Pfizer vaccine, which worked out really well for Grant County. We were able to store and hold and then become a main distribution site for all of Grant County and then the surrounding counties. Although Samaritan set up a drive-through vaccine right here at our main outpatient clinic, working with Unified Command, which Teresa is one of the Unified Commander, Teresa, a leader of that. We were able to work with them and then fairly quickly set up outreach vaccine clinics, one in Quincy and then one up in Cooley Medical. And then shortly after that, set up mass vaccination out at our fairgrounds. And the first weekend we were out there, we vaccinated just shy of 1,000 people. So I don't know that I have the number off the top of my head, but I bet you Teresa does, of how many we vaccinated total at those mass vaccination events. But then over the last couple of months doing vaccination events every 3 weeks, we have transitioned to step back a little bit from using Samaritan employees as volunteers, as that was all above and beyond their regular workday. We've transitioned the command of the vaccination events to Unified Command, which is basically our public health district, our sheriff's department, and then representatives from many health clinics and facilities in the area. And so they are now staffing, coordinating, and manning those events. So I will let Teresa talk from there a little bit more.
Hi, good morning, everyone. So a couple of things to share. In particular is with what Dr. Carter had shared with you. We only had one Pfizer site in Grant County. Samaritan was the only facility in our county that had that deep cold storage, and Moderna was like this vaccine that nobody could get their hands on. And so our other facilities would get little bits of Moderna here and there. And so we had to quickly mobilize the use of Samaritan Healthcare and their deep cold storage to start planning for our site. Now, Grant County has just under 100,000 residents, but we're a very large county. So our goal was to make sure that somebody could get access to the vaccine, within the 20, 40-minute drive. And for some, that's still a bit of a burden, and we'd like to get that even shorter if we could. But during those early days, that's what we had to work with, and as Dr. Carter shared with, getting to some of our more rural communities that didn't have access to the vaccine and didn't have the staffing needs. And as we've transitioned, we use a kind of a multi-mode approach to getting vaccines out to our community. So we have the mass vaccination sites that people can register for and come down. We use community health workers to do outreach in some of our migrant farm work communities, or people that just don't speak English and may not understand the vaccine and its purpose and how safe it is. So they're going out and educating individuals. They're on site at our clinics. So it goes beyond just Samaritan having to staff it to this whole workforce out there. We have a vaccine task force that each of our hospitals and clinics participate in, and then we have what's called an incident management team, and that is kind of that ICS structure where the sheriff's office assists us with traffic flow. We have a safety officer that comes to us out of fire services, folks that deal with emergencies on a more regular basis than we do, and we bring our medical and public health expertise to the table to be able to provide a safe clinic environment so we can get those vaccines out to the communities. Now that many of our pharmacies have vaccines, we are starting to feel less urgency about getting vaccine out to our communities because of some of the federal programs that are out there. But we have that equity lens that we have to continue to apply and just keep asking the questions, are we able to get the vaccines to folks? Our medical providers are in their medical homes and they're used to the patients coming to them with the exception of a few outreach mobile clinics. And public health, we're used to going out to the public and taking our interventions. My staff go out and inspect restaurants, and now they're at a mass vaccination clinic. And we know those mechanisms for communicating with the public and then utilizing the staff for vaccinations. I have 2 staff that are nurses. So I definitely can't staff up a mass vaccination clinic, and that's where I rely on Dr. Carter and her team to provide us vaccinators, and we can bring kind of some additional infrastructure to those events. Anything else I can help fill questions?
I have a question for you. I actually don't know the answer to this. I'm curious about this. There was recent federal guidance that changed who could vaccinate, who could be a vaccinator. And one of the groups that was included is one that we've been advocating for and that the state now has added to their list is veterinarians. And I'm curious if you've had veterinarians volunteer or if any other kind of unusual, maybe unusual types of vaccinators, or if not, if you're thinking about reaching out to them.
Yeah, we haven't included them. We have a registration process on our website that folks can go and let us know if they're interested in helping out. But we have been able to tap into our EMS providers. With this emergency declaration, we can use EMTs, advanced EMTs and paramedics to administer the vaccines. We utilized this approach with H1N1, so it was actually one of the easier systems just to re-engage once again. To come out to our sites and fill those voids out in the community. We even had a couple EMS providers go to people's homes that couldn't come into the clinic. So we'd get a hold of them and they would take the vaccine to the patient.
Great, thank you.
Can I just add one thing, Cassie? Because I don't think that Teresa, I mean, I think she hit on it, but I think that the synergy between traditional in the clinic healthcare and public health, I think where the strength was at is that the unified commander, I guess IMT is what she's calling it, it leveraged different strengths on different people, right? So we have a large FQHC that has a very highly underserved population, and we were able to leverage their skills in accessing that community. And they weren't necessarily, they've been involved in the incident command from the beginning, but using them and as our access point to some of that agricultural community. And of course, I think everybody knows, maybe Grant County in our region, we expect that this phase of agricultural workers is going to be huge for us. So it's nice that we had kind of this practice time to build up and be ready for this, because we think this is going to be a big phase. Great,
thank you. And for folks who don't know, FQHC is a federally qualified health center. It's in your community. Is it the Yakima Farm Workers Clinic?
It's Mosaic Community Health.
Mosaic Community Health, okay.
Yep. And Columbia Basin Health Association and Mattawa Clinic. So we have three organizations in Grant County.
Great, thanks. All right, Dr. Markovich. Oh, sorry.
Oh, just the one thing I would add around phase 3 and that transition. This is what's so critical about vaccine is we know our communities are ready to be opened up. And we always say they might be done with COVID, as you indicated with folks not wearing masks, but COVID's not done with us. And just continuing those mitigation efforts with masking, staying home when we're sick, but getting the vaccine when your turn comes up, taking advantage of that opportunity. Talk with your healthcare provider if you have questions about the vaccine, because there's still a lot of misinformation out there. That this truly is one of our last tools in our toolbox to get past the pandemic is everybody taking advantage of the vaccine that can. If you can't, we understand, but if you can, please do your part and get your vaccine.
I think you all would support the message that at this point of the 3 vaccines available, the best vaccine for you is the first vaccine you can get.
Exactly.
Yep. I think we believe them all to be clinically equivalent and are really excited about them. And there's reasons why you might, Johnson & Johnson, if you're about to take a big trip, might be the best thing for you to get because you'll be done faster. But whichever one is offered, that's the one to take. All right, Dr. Markovich, we'd love to hear about your experience treating COVID patients. What has changed over the time? What have you learned? What would your advice be for people moving forward about this disease? I think we see complacency, like it's not so bad. I won't get that sick. And I think it's always good to remind people that people still get really sick.
Yeah, that's right. I do want to clarify that I am a critical care physician, so I work primarily in the ICU. I also have a pulmonary clinic as well, so I'm pulmonary and critical care. So we started, actually a little over a year ago, having some of the first COVID ICU patients. And I'll say that a lot has changed, particularly in critical care for these patients over the past year. When we started, we didn't really know much about it. We knew that the patients are extremely unstable when they end up in the ICU with severe COVID. They have extremely, their care is extremely resource heavy. So these patients require a lot of staff to take care of them, a lot of equipment. The respiratory therapists, are crucial for these patients. We had to really do a lot of upstaffing and a lot of surge staffing for these patients. And at this time last year, some of the challenges were the extreme shortage of PPE. We were having to reuse a lot of PPE that we normally would throw out after each patient. For example, we have cappers, which are the helmets that you wear to protect yourself and filter air. And the face shields are supposed to be thrown out every time you finish seeing a patient. We were having to reuse them for a week or longer at a time because we just didn't have enough of them, to the point where, with all the cleaning that we were having to do, we could barely see out of our face shields to see our patients. It was a pretty extreme situation. The other issue was that we didn't know the different complications that could happen for people with COVID. One example was when we started in March, we didn't know that patients with COVID had increased risk for blood clots, for example, strokes, pulmonary embolisms, DVTs or blood clots to the legs. That was not something that had been reported because it hadn't been recognized yet. And we started seeing patients with strokes that came out of the blue. So over time, we realized that COVID actually can cause severe blood clots, and we ended up changing how we help to prevent them, how we treat with preventative measures for these kinds of patients. In addition, over the past year, there's been updates in medications. There's been more research that's been getting conducted over which medications are effective or potentially effective, which medications are not. So there's been a lot of updating as far as how we treat the patients. There's also been the development of convalescent plasma, which is plasma donated from people who have recovered from COVID. So the treatment options have been constantly changing and still are changing based on new data. Now, we don't have the PPE issue that we used to have. So we are able to kind of use our PPE in the standard way and not have to reuse items at this point. We also are much more familiar with the type of respiratory failure these patients get and how long a course, if they have to get intubated, how long a course that they might have to be on a ventilator. So there is a little bit more comfort in having experience with these patients. However, these patients are still extremely resource heavy. We've had patients in the ICU for months at a time, critically ill, including young patients. This is something that I know we talk a lot about patients who are older or who have underlying medical problems are at increased risk of death. But we do see younger patients in their 40s or 30s on ventilators, needing tracheostomies and chronic ventilators because of this. They might not necessarily die from it, but they are chronically, severely debilitated. And some of them, many of them actually aren't able to go back to work. So it is a major issue. My other concern is that even though the numbers are improving, we're getting new admissions every day. This week that I was actually working in the ICU just this last week, I finished yesterday. And I'm concerned because I've admitted or transferred to the ICU more patients with COVID just this last week than I did for all of February. So my concern, now I don't know if this is a trend or if this is just a fluke, but my worry is that we're going into the next phase, and my worry is that people might not take it as seriously. It is still out there, and it's still getting spread in the community, and it still can cause severe disease.
Thank you so much. I think that's a really important point to continue to make, that I think there, and I know the governor's office has really struggled with this about what's the message. We can move forward. We are moving forward to phase 3 today. That doesn't mean this is over. It doesn't mean people aren't still getting really, really sick from this disease. And so to not take it lightly, to not, to still be as cautious as possible while being in phase 3, I think is critical. The other thing I wanted to mention is that we are working on a piece of legislation. I think this really follows up to what you were saying, is that this legislation is Senate Bill 5271, and it's provides some liability protection for the duration of the pandemic or the duration of the state of emergency. And so what it does is allows, it really recognizes that the standard of care has changed so dramatically over time. And so as an example, a patient who came to the hospital last March or April probably was not put in a prone position on a ventilator because that wasn't knowledge that we had, or might not have been treated for blood clots because that wasn't knowledge that we had. And as the knowledge has evolved, the standard of care has evolved, and it's evolved really quickly. And a lot of times it's, it's like day to day. I think Dr. Markozich, please chime in on this, but my understanding is you all are often changing things day to day, week to week, at kind of at the most about how you're caring for patients. So we're glad that this bill has passed the Senate, is moving through the House, State House. It looks like hopefully it will pass, but it really does recognize how the standard of care has changed and provide some protection for that. And our general counsel is also on the line. Tay, if you've got anything you'd like to add, please do, about the piece of legislation.
Yeah, I think that you said it well. The only thing that I would add is that the majority of states in the country have offered some form of protection to providers in this space. Washington State received an F in this area from a national organization. I believe it was the Journal of Health Affairs that was evaluating how well providers who were responding to the pandemic were being supported by their states. We're hoping this bill helps rectify that.
Great, thank you. Dr. Markozich, any comment you'd have about how quickly that standard changes, and that just like, I know you all feel like you're on a really fast moving treadmill to keep up with the latest research from all around the globe.
Yeah, it was changing extremely quickly. It still changes very quickly now, but particularly in the early days, March and April, it was changing so fast that we couldn't even wait for data to get published. The way we were all discussing this is that I had colleagues from all over the country that were texting me and texting each other. We were all discussing, how do you treat these patients? And we were distributing information by text messaging, and some people were coming up with some websites to just consolidate all the information, but it was changing so fast that from one day to the next, there would be new information that was available.
Right, and the survival rates have improved significantly, but they're still not. There's still plenty of people who get really sick. So I think that again, that message of this is not a disease to be trifled with. Don't take it lightly. I had plans to take my kids to go get some ice cream when we were in Eastern Washington. We walked right out because there were so many people in the place that didn't have their masks on. Just like not going to do it. So it's worrisome about that sense of it's over. And I think, as Teresa said, people may be done with COVID, but COVID's not done with us. All right, so I would like to get to the questions. I don't know if anyone's going to have a thought on this because I think this is too new news, but I'll see if anyone does. Teresa, maybe, or Dr. Maybe you all do. The question is, I was wondering what everyone's thoughts were on the announcement today from AstraZeneca that their vaccine is over 75% effective. Given the mishaps that they've dealt with early in the process, how confident are you with this new vaccine that could be coming in the U.S. in the coming weeks? Could be in the U.S. in the coming weeks. I have not had a chance to look at the data. And as when Johnson & Johnson came, we had the same. We were able to listen to a number of really informative webcasts out of the CDC about Johnson & Johnson. I don't think those have happened for AstraZeneca. Anybody else have deep knowledge of the AstraZeneca vaccine?
No.
Okay. And Taya, they haven't done any of the webcasts, the same webcasts that they did for the other vaccines yet, have they?
No, I have not seen any of those educational webinars planned.
Yeah.
Those typically come once we receive the emergency use authorization. And so I think it will be probably 3 to 4 weeks between now and when we receive that. So at that point, I think we can expect those education opportunities to start.
Yeah, and those have been terrific. The education opportunities out of CDC have been amazing. They're really thorough, go through the data in extreme detail of the efficacy, and then go through the storage, packaging, administration in extreme detail as well. And I know that the hospital association staff and providers all around the country listen to them exceptionally carefully. So we'll look forward to that. Okay, Teresa or Dr. Carter, can you talk more about the challenges during the phase that includes agricultural workers, and do you have special strategies for dealing with that? Specific days devoted to them at mass vaccination sites, more on-site vaccination clinics, and then what problems are you seeing or do you anticipate with vaccine hesitancy? So a bunch of questions about working with agricultural workers. And I think an important thing about agricultural workers is, and Teresa and Dr. Carter, you can tell us if this is wrong, we've been thinking about agricultural workers both as the people who are actually working in the field and also the people who are processing the food. So both, I think people tend to think of it just as a field job and not think about that there's a bunch of work that happens afterwards to store, process, package, etc. So that would be helpful to hear as well.
So I will talk about vaccine hesitancy, but Teresa has a lot of information about outreach to agricultural workers. So from a vaccine hesitancy perspective, I think that in general, we have a lot of vaccine hesitancy, and I don't know that we're unique, but it feels overwhelming some days in Grant County. It goes back to what we talked about when the vaccines first came out. They came around fast. There's a lot of unknowns. People don't trust medicine and science that happen that fast. So we do have a fair amount of that in Grant County, and it may be partly why, Cassie, you found so many people without masks when you came to Grant County, which is not vaccine hesitancy, but hesitancy about the existence of COVID, let's put it that way. So I do think that there's hesitancy. I think when you start introducing language barriers, there's a bit more hesitancy, again, because there's a lack of understanding. And I will let Teresa touch on that because I know that they've addressed that the best they can with what they've got going on. So Teresa, I'll let you talk about the outreach and the tracking and whatnot.
Sure. So a couple of points to make with the ag workers, and I appreciate you saying, because we have the processing plants as well. And a lot of times that's an indoor environment, and they too qualify for the vaccine. We have temporary workers that come here to work, as well as workers that are here year round, but may have language barriers and mistrust with kind of traditional clinic environments and governments such as public health. That's where those community health workers play such a critical role. When COVID hit us last March, the clinics started reaching out to the farms to be able to provide education on site about hand washing. What is this virus and what does it mean for them working and sleeping and living in these facilities? And they did a fantastic job. They started at Walmart when the buses would come in to buy their supplies to actually going on site. So education is very important, and they're very trusted. Without community health workers, I think we would see more vaccine hesitancy in our communities. They take this very scientific information and they make it understandable and people they trust. Our staff here at the health district, we investigate every COVID-19 case. We did not contract that work out. So we spoke with the farmers and the farm workers when they were sick with COVID-19, and they would ask our staff so many questions about not understanding what this virus is and how they're to keep themselves safe while they're here. And making sure that they're getting correct information and that they can trust the information that they're hearing. We've used that to help plan for their return this year with both still having COVID precautions in place and then getting them access to the vaccine. We just held a clinic in Quincy this weekend, and the community health workers did a lot of the outreach, and we had a number of vans show up at our clinic, and we registered them on site to take advantage of that opportunity. We also have what we call pop-up clinics, where our clinics will get an allocation, oftentimes from Samaritan, or it might be one of the other clinics, and they'll take the vaccine out to the field. So they'll coordinate with the farmer, because that farmer could have workers that live in the community or are contracted, what we call H2A workers. So going on site is one good avenue. The mass vaccination sites are good when they're taken to the community. We don't have one of the state mass vaccination sites in Grant County, so we take it out to our community, as I spoke to earlier. We're also involved in statewide planning. So we have a group that gets together, it seems like weekly, with our state health department and local public health to talk about how do we coordinate the ag community vaccinations and disease control when they're crossing our counties from week to week. So you could have one farmer that's in 3 counties in central Washington. How do we track their vaccination? Because I saw the question about how do you make sure they get the second vaccine? By having them registered and working very closely with those farmers, we can know where they're located to make sure that they're getting their second vaccine. And working directly with the farmers is also very important, because they will work very hard to make sure that those that want the vaccine get it. We were concerned about vaccine hesitancy among the ag community, and it's only been open for a short time, and not all the workers are here yet, but we're not seeing the level of vaccine hesitancy that we were concerned about. And I think it comes down to just good education. The vaccine's been here for a while, so they're starting to hear more about it. We're trying to get more information out on our Spanish radio stations to educate folks about the vaccine and COVID precautions. We're kind of in that bubble right now, right? Of we have vaccine that we're trying to push out and get into as many arms as we can every week, but we're still having to mitigate COVID-19. And daily conversations about potential outbreaks. All of that plays into, and I saw the question about keeping us in phase 3, and could we go back to phase 2? Absolutely, we could get pushed back to phase 2 if we don't maintain our COVID precautions and getting vaccine in as many arms as we can. So I hope that answers the question on the ag workers. We've been talking about them before the vaccine was even here, because we wanted to have a good plan for their arrival when they got here.
Thank you. I also would point out a really important message that public health, hospitals, other vaccine providers, and the governor have been clear about, is that immigrants are welcome to get the vaccine. There is no immigration consequence of receiving a vaccine. You do not have to be a citizen of this country to get a vaccine. There would be no reporting to immigration authorities. And so continuing to make sure that that is widely understood by people across the state. And that's not the case in every other state. And the fact that some states are restricting vaccine to only citizens, I would say we at the Hospital Association find pretty reprehensible. So we are really proud to be part of a state that has a very different approach. All right, Dr. Markovic, a question for you to pronounce your name. And I think I pronounced it right, but if I didn't, please say it.
You did pronounce it correctly. It's Markovic.
Thank you. Thank you. Have hospitals received any directions from DOH or CDC about tracking breakthrough cases? So these are cases that the patient has gotten a vaccine or has been fully vaccinated and then still has gotten COVID. And yes, DOH wants us to report all of those cases to them. Have you all seen any, Dr. Markovic or Dr. Carter, have you all seen any breakthrough cases?
We've had, sorry, go ahead.
Okay, so I personally have not seen any breakthrough cases. I have had some patients come into the hospital who received their their first dose, but they usually, the patients I've seen who have gotten their first dose and came in with COVID are patients who started getting symptoms just a couple of days after getting their first dose. So they were probably infected or exposed even before getting the first dose. So they weren't, their immune system hadn't even had a chance to respond yet. So those are the only patients I've seen come into the hospital who have received any doses of the vaccine.
And we've had a couple of employees that have been fully vaccinated and then become positive, but we don't have definitive results yet. That just happened in the last few days. So we have no blanket recommendations from the DOH, but they're working with us to get through that process. So the answer is yes, but we don't manage it on our own. The state's working with us.
Yeah, I think that DOH is particularly looking for variants in those cases. But
vaccine uptake is a standard question during a disease investigation.
Yeah. Dr. Lindquist said the State Department of Health would be the best source on this, but my understanding is, and you really should confirm this with them, is that they have not seen any breakthrough cases where anyone's gotten severely ill. But please do confirm that with them. Are there any requirements for healthcare systems to track or report long hauler or long COVID patients to DOH or federal agencies? I'm not aware of any. Anybody else? Okay.
I've not been told of any. We do actually. There are a few different clinics that or different hospitals that are setting up some long haul clinics for these patients, and they're internally tracking data on the symptoms that the patients have, and how long they're dealing with symptoms. But we have not gotten any direction that any of this is reportable at this time.
I think a good panelist we might look for in the next week or two is someone who is working, as Dr. Markovich noted, there are several hospitals that have set up long haul clinics. We could look for a leader of one of those clinics. The second question is, how standardized has treatment for these patients become? And I don't know. I bet it's not very standardized because it's such a new phenomenon. I think as we described with COVID, like learning how to treat patients with COVID, just the fast COVID was really challenging. I think the long COVID is really very complex and hard to understand.
Yeah, and just to pitch in, I'm actually working on developing a long haul COVID clinic at Overlake, and there is no data behind, or there are no standardized treatments. There's no data behind, how to treat the chronic fatigue that a lot of patients get, or the memory issues that patients get. There's a lot of right now data gathering. So, but there's no consensus on how to best treat these patients.
And that's another reason we would say people continue to wear their masks and social distance, is the chance of the possibility of getting COVID and having it be a long-term health impact is a big deal, or a huge deal for the rest of people's lives. Although we don't know how long, but for extended period. With the recent spike in cases, do we think it stems from spring breakers? I don't know. I think it stems. Everyone can chime in on what they think, what their theory is. I think it stems from things are fine now. That's what people think. Like there's less hospitals. People hear the hospitals are not overwhelmed. There's fewer cases. Like as Teresa said, people think they're done with COVID, even though COVID isn't done with them. I think it's the complacency. It's the folks who didn't have their masks on in the ice cream store. Yeah.
Mhm.
Yeah. Spring break is still a little premature to see cases emerging from that. I can only speak to Grant County. We're seeing a lot more younger people. Just this last week, over 20% of our cases were in children to young adults.
And this is part of why we're really excited about the opening up of all vaccines on May 1st to everyone, because there's Dr. Lindquist, again, he speaks really eloquently about this. There's, vaccine is intended to stop serious disease, but it also has another piece, which is stopping transmissibility. And the most transmissibility seems to be in those younger adults right now. So being able to get the 20 and 30-year-olds in for vaccines so that they will hopefully stop transmitting disease, I think is a big deal. How likely is the spike to move us backwards in phases? I don't have enough insight into exactly what the metrics look like compared to the phasing. So that would be a question, I think, to the governor's office, but any spike is going to be of concern for sure. So, if you want to keep moving forward, wear your mask. Anybody else have comments about that? Okay. Do we have any update in terms of the percentage of healthcare workers declining to receive a vaccine to date? Can you let us know what that looks like at Overlake and at Samaritan? And maybe Teresa, if you've got a view into all the providers across Grant County, that'd be helpful too.
So at Samaritan, I don't know that we specifically have polled our employees and they've declined, but we are approaching a 50% vaccination rate for our employed staff.
Yeah, the only thing I would add to that is we're starting to see their registrations increasing. So I think they had the time to kind of observe, make a decision for themselves. But I have noticed that some of our mass vaccination clinics, we're starting to see more healthcare workers coming through. And it's just providing that time for people to make a self-assessment on the safety of the vaccine, and I'm pleased to see more. Obviously, we need a lot more, as well as in the education system, to get a better sense of how well we're covered across our communities.
I don't have exact data, or I don't really have data on the numbers at Overlake, but I do know that out of the ICU staff, as well as the pulmonary clinic staff, our vaccination rates are approaching 100%. And I think a lot of it is because we're very, we have seen this from the beginning and have seen how bad it is. And pretty much every nurse, every respiratory therapist, every technician who has worked in the ICU or is working in the ICU has received both doses of the vaccine. Great.
That's such a good comment that the folks who are most familiar with how terrible this is are eager to be at the front of the line to get vaccinated, to get it completed. Okay, Taya, I may hand this question to you. Is 5271 about protecting providers from malpractice or other lawsuits if something goes seriously wrong with the patient because of the steep learning curve with COVID?
Yes, sorry, trying to get myself off of mute. It really is designed to address a number of the practice considerations for healthcare providers during this pandemic response. Yes, absolutely. There has been massively changing clinical guidance and treatment protocols throughout the pandemic. In a medical malpractice lawsuit, the way that the lawsuit is typically evaluated is to have an expert come in and opine on the type of care that should have been provided in the same or similar circumstances. In the pandemic, we don't have same or similar circumstances, and there's no expert that can come in and opine on what was the right thing to do in Washington State on March 22nd versus April 14th with the supply limitations or the patient loads that we were dealing with in terms of, was there room in the ICU? Were we caring for patients on acute care floors that typically would be in the ICU? There's really no good way to get an expert opinion on that. And so what this bill does is recognize those extraordinary circumstances, as well as the circumstances that were raised by the governor's non-urgent procedures proclamation, where providers were told that they could not provide care to patients unless it would result in patient harm within the next 3 months. Providers have never seen any directive like that before from the government. There's no expert way of evaluating whether harm would occur or not. A lot of patients went without diagnostic tests, and for a diagnostic test to be missed in that period of time, maybe there wasn't harm in those 3 months. There might have been a cancer diagnosis that was subsequently missed. So it was and continues to be a really extraordinary set of a really extraordinary practice environment, and that's what this bill is recognizing. It allows for patients to be able to bring their medical malpractice lawsuits. It also recognizes the difficulty of the practice environment, and so provides the ability for practitioners to be able to rely on guidance from state and federal officials, and recognizes the limitations in practice with respect to supplies and the places where patients were being cared for. So that's the approach of the bill. And in the chat, I provided a link not only to the bill, but also to the Health Affairs article that I referenced earlier.
Thanks, Taya. And Taya is the general counsel for the Washington State Hospital Association. And I also would note that we still operate under a non-urgent procedures proclamation, that the hospitals have a responsibility to cancel non-urgent procedures if they need to do so. And a lot of that happened. There was a lot of cancellations of those procedures over especially November, December, January, to make room for COVID patients. Looking forward, how likely do we think it is that hospitalization rates and ICU capacity numbers could again reach the levels we saw over the winter wave? Dr. Markovic, you want to tackle that one?
I'm not sure I can speak to how likely I think it might happen. I am worried that we might get that way, but I feel like at this point, we're fighting a race. We're fighting a race on getting as many people vaccinated as possible before we start to see another surge. And I think that's the crucial thing, is that we need to keep on taking all the precautions that we're taking and then just vaccinate as many people as possible. I think if we can get the vaccination rates high enough, then hopefully we can avoid a surge. But my worry is that we might get a surge if we get too lax, or if the vaccination rates are too slow for what's going on.
Thank you. I agree. Very, very definitely not the time to be complacent. Teresa, I think this is a question for you. Do you have any, I don't think we have data on how many extra doses vaccination sites have at the end of the day. The Department of Health might, but I know we don't at the Hospital Association. How do you distribute any extra doses at the end of the day? How do you go about doing that?
Yeah, so we create a wait list for each of our events, and we prioritize that list based on who is currently eligible for the vaccine or in the next tier that would be coming in the, like in this case, on the 31st, and go down the list from there. We also really honed in towards the end of the clinic, pausing on filling syringes so that we don't end up with too many vaccines. It's usually a handful of doses, and we've yet to waste one. We find arms to get them in by the end of the day. I think that it's nice to have wait lists. We've encouraged all of our clinics and hospitals maintain a wait list of eligible participants. And if you get through that list, move on to your list of vaccine clinic volunteers. They're eligible, or the next tier coming up.
Great.
At Samaritan, we do vaccines Monday through Friday at the clinic themselves in the drive-through, and we schedule those patients so we have a better idea of who's coming. I would say that we really probably only have 2 to 3 at the end of the day that have not been administered. And we have a wait list like Teresa described, prioritize the same way. But what we often will do, if that wait list is not existent or they're too far out from being eligible, we will actually call into the next day or two ahead and give them that day. And oftentimes we'll have a nurse that hadn't got hers yet and we'll want one.
I know I live not too far from the city of King County Rainier Beach vaccination site, and people are lining up there every day and they're going through the list by age. So they just start, calling out, anybody here who's 64, anybody here who's 63, and the reports of the neighborhood they've gotten down to 58, 57 on some days, and some days it's at 62. But that's how they're using it. I think that's all the questions that I see. If I missed your question, would you put it back in the chat or speak up, or anyone who wants to ask a question orally, please do so now. Okay, would it be of interest? It sounds like there, at least for one person, it'd be of interest for us to have someone who's working with the long haul COVID population to come and speak in a future briefing. If anyone has anything else they'd like to hear, particularly, we'd be happy to hear it. And we always welcome your feedback about if this continues to be useful or not. If it's not, please let us know. Or if it, I guess either way, let us know if you want us to keep doing it. I'll conclude by saying thank you so much to Dr. Carter.